Our brain's complicated. We have maybe 3 levels of brain if you want to divide it that way, but our cognitive brain, what we think, is only part of where we live. We think it's kind of the whole thing. It's just, well, I'm a thinking person. But we all know we have emotions. Kids are learning that they have emotions. You don't choose emotions. That's part of your brain. And the emotional part of your brain is where your attachments and your connections are. Then there's the deeper brain that's just regulating our heart and our respiration. And that's pretty well going to be fixed, or else we aren't going to keep surviving. So for kids, it's coming to grips with the cognitive regulation, the upper brain kind of being able to mediate that emotional brain. Sometimes with toxic stress or repeated stress, kids get their emotional fear mechanisms kind of set always on alert or high alert, and they're just afraid all the time because they needed to be, or because they're afraid and there was no one around there. And that fear can then both damage their mechanisms of building a good brain mechanism. Well, trauma and stress are different. Stress is a normal physiologic reaction. It can be very severe stress or a little bit of stress, but when we use the word trauma, we really mean causing an injury. That's kind of stress that would cause an injury. And with childhood experiences, that's usually lots of stress over a bit of time and without the buffer of a relationship.
You know, one of the challenges in teaching people about these issues is that we all tend to use language a little bit differently. I think over time it's going to be really important for people to start being a little bit more precise about what some of these different terms mean. I know, for example, the ACEs, the Adverse Childhood Experiences, refer to a specific set of experiences that could broadly fall into the category of bad things. And then there are people who talk about developmental trauma, and they're talking about things that might include an adverse childhood experience, but that concept of developmental trauma actually is quite broad. It's broader than just the simple adverse childhood experiences.
People often divide up stress into 3 types. Normal stress, just positive stress, the things that happen day to day that are part of making us a good person. We develop with that stress. Then there's tolerable stress, which is really stress we wouldn't like to have, we don't want to have, but it's tolerable or survivable because we have a relationship, we have someone that we're connected to that can help buffer that stress. And then if you don't have that buffer, then it can be actually damaging stress or toxic stress.
I think over time, the people who are hearing about this, in the beginning, what I'd recommend is you just kind of, all of this stuff is sort of code word for bad stuff that happens to kids. What I really think is important is that when the general population, when the general public hears about some of these concepts, that they can connect to it.
If you don't have a relationship, if it happens without that buffer, if you just need to think about, we talk about attachments, we talk about loving relationships and caring, but those are actually things that are true in a kid's environment that affect their brain and protect them from lots of things. So a death in the family could be very stressful for a child. They'll mourn, they'll have a reaction, but if they have a relationship, then it's not going to be damaging to them. It will be something they can survive and grow and build from. Not that it won't affect the child, but it won't damage them in a way. But if you then don't have that relationship, if you have a child in isolation or who's being neglected or doesn't have connections or loses connections one after another, doesn't have good stable relationships and attachments, then that can become toxic or damaging.
It's important to remember that the event itself is not the trauma. The trauma is how the person internally manages that experience. And so there are people who will have different degrees of, if you will, regulation capabilities. And so it's completely conceivable to have an event where one person is overwhelmed and that event becomes traumatic, and another person is impacted but not overwhelmed and recovers very quickly, and for them that was not a traumatic event. So in many ways the trauma is the way the individual manages the experience, and in some extreme cases you can have people who are easily overwhelmed by everyday typical things that you and I might not even think of as stressful, and then things that you and I might be overwhelmed by, somebody who's got lots of experience and the capacity for resilience might deal with that event as if it was challenging but not overwhelming.
By self-regulation, we're really talking about essentially frontal lobe development, where you're learning to regulate your emotional reactions and your behavior and your responses. You have to essentially buffer yourself a little bit by having some controls. Well, kids at 2 and 1 don't have that at all. I know 2-year-old is regulated very well, but we expect 5-year-olds to be better, able to self-regulate. So I think they mix up with stress only because the timing of one and the other, and stress can interfere with self-regulation. So it interferes with that development, that frontal lobe development.
Probably the most important epidemiological studies that have been done in the last 50 years are called the ACE studies, and that stands for Adverse Childhood Experiences. And what a team from Kaiser Permanente in California and the CDC in Atlanta looked at 17,000 adults and then looked at their health and a lot of other aspects of functioning. But one of the most astounding findings was that the risk for health problems in adult life was increased between 4 to 12 times if the individual had adverse childhood experiences. And those adverse childhood experiences were defined as a set of specific events. And so really what we know is that when children grow up in environments where there's threat, chaos, unpredictability, and their stress response systems are overwhelmed, that influences not just how they do in school, it doesn't influence just their mental health, it influences how their heart works, how their lungs work, how their gut works, how their pancreas works, and it will increase risk for heart disease and diabetes and overeating and all kinds of things that are more commonly thought of as health problems. But the interesting thing is your risk for these health problems is higher if you have adverse childhood experiences than if you smoke. And so it's an incredibly powerful association, and it's something that we need to be better at educating the population about, and of course, better at trying to decrease adverse experiences for children.
Maybe one thing is to think about is to differentiate a little bit neglect from toxic stress, because neglect keeps kids from developing those brain areas, and toxic stress may damage those brain areas, and they both can be very, very severe and make it hard for the child to be kind of normally reacting to you. Well, I think we're becoming more and more aware that lots of behavior that is really difficult behavior might not just be a bad kid or a kid that's trying to cause trouble, but a reaction or a response that is from toxic stress. So we're talking about all of us becoming more aware of that, what might have happened to that child's brain that would explain or help us understand what's going on, and also help us know what maybe some of the best responses would be. The other thing is, whenever kids acting out, we always want to ask the question, why is this happening? And often it is communication. That's the whole functional behavioral analysis kind of way of looking at behavior is communication, and it's functional communication. If kids are behaving badly, it's very likely that they're getting something from that behavior that seems necessary. So we ask that question, but if it's a simple thing, like any 3 or 4-year-old, they need a little more attention, they're a little anxious about going to their aunts, or they, those we can figure out that, and we can give them a way to communicate. Foster parents are going to know by definition almost that there have been some real stresses, and probably even some toxic stresses, because it means the child was not safe, the people around them were not able to keep them safe. We don't remove children, we don't want to remove children unless that's really the only way to keep them safe. So you can just guess that they are, or that they've had that. That would be a reasonable assumption.
It's important that you know the development that is normal for children this age. You know what milestones they should be reaching, because we're going to want to compare that behavior to the behavior that we're seeing in these children. So sleeping and eating disruptions are often a symptom of trauma. This has to be measured against what the child's normal sleeping and eating patterns were before the trauma and what's appropriate for their age. You may begin to see some withdrawal. Children that are normally engaging and interacting with adults, it may be a symptom of trauma if they're no longer doing those things. You might see an increase in aggressive behaviors, although again, this has to be compared to what is normal for that developmental age.
If it's that they have been left or had so many relationships broken that they have been so stressed and so much mourning that they just don't want to relate to anybody. Their function of their behavior is you keep them away from you. I mean, you are not going to get close to me because it's too hard for someone to, for me, when I get close to people and then they leave.
And we also see an increase in separation anxiety. We need to be aware of the fact that children this age often have separation anxiety. This would be above and beyond what is normal or a new behavior for that child. Inconsolable crying could also be a symptom of trauma, although in some children this could be due to other things. So we want to be aware of the child's medical history and make sure there's not a medical problem where they're unable to be soothed, that this would be a behavior that is again different from what was going on before the traumatic event. New anxieties or worries that the children may have that again are not developmentally appropriate are also a symptom of trauma. These children are more verbal and often able to tell us what's going on with them, so it's a little bit easier to recognize those symptoms. We're going to look again for disturbances in their routines, their sleeping and their eating patterns. We're going to look again for aggression that is not within the normal developmental range or that is new. Difficulties in school may start occurring if there's been a traumatic event with children ages 6 to 11. These could be non-compliance issues, or these could just be trouble concentrating from hyperarousal. And other issues at school may include truancy or aggression or not getting along with peers. And it's important to note that in kids 6 and older, depression is often in the form of irritability and not sadness. In children ages 12 to 18, when they've experienced a trauma, we often see what look like conduct problems, but they're sometimes due to a traumatic event. So we see antisocial behavior, noncompliance with rules, aggression, school failure, truancy issues. We may see substance abuse, promiscuity, and you may also start to see symptoms of depression and anxiety and withdrawal.
There are a range of ways that a child can express and cope with their stress and distress. And that just because a child is not acting out, just because a child is not having temper tantrums or having bedwetting or some of the classic externalizing symptoms, that they still may be hurting inside. And in fact, what we're learning is that more children than not, when exposed to developmental trauma, manage those symptoms and deal with it internally in ways that are very rarely easily observed by adults. So I think one of the most important learnings is to recognize that just because a child is not acting out and compliant and a good child doesn't mean that their life circumstances and their exposure to trauma has not impacted how they're functioning.
We're also going to talk a little bit about things that you might be able to do to help a child who's been traumatized, and the types of things that may help vary depending on the child's age. In Project Safe Start Nebraska, we work all with children aged 0 to 5. So a lot of the babies that we see are very dysregulated. They're unable to keep a regular sleeping schedule, they're not eating, they're not engaging, and they're difficult to soothe. And what we try to do is help every caregiver in that situation make the baby feel safe. And we do this by engaging them in a relationship that's consistent and that's stable and that's nurturing. So we encourage parents and caregivers to watch the baby and see what they need and respond. We encourage them to know the history and know things that may upset the baby, like changes in their routine or environmental triggers that might make them upset, and to use the soothing skills that work. I think it's a mistake for us to assume that we know what's going to work for all kids. So it's kind of difficult when we're talking about trauma to apply, here's how you fix this, because different kids need different types of soothing to regulate them and different things in their environment.
Probably the most powerful factor in both healing from trauma and being resilient to a traumatic experience is having a set of healthy relational connections. So it turns out that the relational buffer a child has will be a major determinant in how they experience a life-threatening event. And so we've found, for example, that it's a more powerful predictor of long-term outcome to look at the presence of healthy relational individuals in a child's life than it is to actually add up adverse childhood experiences. And so as we get learn more about this field, I think what we're going to come up against again and again and again is that relationships matter, relationships are protective, relationships heal, and that most relationships that are healing are provided by people who are not therapists. And that's, I think, a really powerful message for the child care workers and the people who take care of children every day, teachers and foster carers and child care providers. They're the ones that are providing the therapeutic experiences. And even though they may not recognize what they're doing as therapy, it's therapeutic.
One of the things that you're going to see across all stages is that these kids will have difficulty regulating their emotions, and so we want to try to assist them in doing this as much as we can. And we sometimes do this with their environment by making sure that things are the same time each day, the same caregiver. If there's objects that are important to them, we want those there. Anything we can do to increase their feelings of safety and control and decrease the feelings that they may have of being overwhelmed. With children aged 0 to 5, some kids are really going to need and like to be held and rocked and touched, and other kids are going to have an aversion to that. So again, there's not a one-size-fits-all for these things. What we really want to teach people to do is to be reading the baby's cues, listening to the baby, knowing when they do certain things, when they hold the baby and rock the baby, it becomes quiet, or if that's not something that's working, that they don't continue to try the same things over and over again.
You know, it's a hard thing to give advice about intervention that will be universally applicable. And, you know, the part of what we've been trying to get better at in our work is to not always use a one-size-fits-all approach. You may end up having two kids that have very similar behaviors that are troublesome, and as you get to know the child and the way they're put together, you would choose to use a certain kind of approach as opposed to another approach with a different child. And I think that's the major challenge of our field for the next, I think, 5 or 10 years, is recognizing that human beings are so complex and the way we deal with these experiences is so variable that if we're really going to help somebody, we really need to get to know that person specifically. And now with that said, there are some general principles that you should always be respectful. You should always try to be attuned to where that child is. You should always try to provide consistency, predictability, introduce rhythm into your interaction with the child. And there are other elements about being honest, being clear, that will help every kind of interaction, whether it's a therapeutic interaction or an educational interaction.
We want to be aware with all of the age groups that behavior has meaning. So when we see these changes in behavior in infants and toddlers or in older children, we want to note the circumstances as they're occurring in, and we want to try to decipher whether or not that is related to the traumatic event. And some of this can be done by any caregiver, but some of this should be done in a therapeutic setting. So even with kids birth to 5, it's appropriate to ask for a referral to a mental health professional if they have symptoms of trauma or if there are concerns about their development or their behavior. In children that are a little bit older, we're going to want to build on their positives and their strengths and their positive experiences. These children, again, are going to have difficulty regulating their emotions. We want to increase their sense of safety, and this may be by the people around them who they feel safe and who they feel respond to them appropriately. It may be the environment that they're in. And it may be that they may feel safe when they have a routine that's consistent and they know what to expect. So we want to make sure that we're letting them know ahead of time when things are going to happen, that we're not springing surprises on them about their daily schedule or that their discipline, everything should be consistent and predictable for them.
Anyone dealing with young kids, to be a little gentle with yourself too. You're not always going to be positive. You're not always going to have the right reaction you would like to have, or that kind of unconditional love to someone, but you still can do it more and as much as you can, and not kind of beat up on yourself because, oh, that was a bad way to do it or whatever. Just kind of keep in mind how important that is.
Most people don't recognize that they themselves probably had some sort of significant developmental challenge. You know, they may have come from a divorced family where there was some conflict, and that falls within the category of adverse childhood experiences, but they may not recognize the impact that that has played in their health.
And I think most important, especially with young children, is to be aware of our own reactions to the stress of caregiving or the child's behavior. These children are going to be particularly impacted by the caregiver's response to them. So they need a caregiver who is calm and confident that they can help them regulate, and who's consistent, does the same things over and over again, that they can predict, if I need help, this is where I can get it. And since they don't have language, their behavior is the way that they're going to communicate this to us.
So you need to kind of be there, calming, soothing, loving, connected. Humor is really important for parents to be sort of mediating that.
And the caregiver should be aware that one day, something that may work very well for a child, they're going to school, it may work for them one day for the caregiver to be very firm and insistent that they are getting ready for school. And the next day, that may not work. So they're going to have to gauge whether or not that's a time where they need to deviate and be flexible and sit down with the child and talk to them when they're a little bit older about what's going on that day. They need to be able to, again, read those cues, and it should be easier in older kids, although kids often don't tell us, they show us how they're feeling. So caregivers need to be sensitive to the fact that sometimes misbehavior, temper tantrums, behaviors that seem regressive or younger than they are not because the child's acting out and being naughty or bad. They're because the child's having significant anxiety, and they're looking to the adults in their environment to reduce that anxiety for them. For older kids, we want to teach them how to express their emotions appropriately, and they may not have the words to say how they're feeling, and they sometimes need an adult to do that for them. So it's important to be able to help them label those emotions, and some of this can be in the form of, I noticed that you're tearing up your room this afternoon, you must be feeling really angry. And reinforcing those times when they do come to us and use their words to describe how they're feeling and do the appropriate things. We want to really reinforce that they handle situations well and increase their sense of control. So we want to talk to them about times when they've been successful at solving problems, when they've been overstimulated or dysregulated. Times at school when they get sent out of class because they aren't concentrating, and then they're able to pull themselves together and come back in the classroom. We want to make sure that all caregivers are able to say to them, you did a really nice job. I'm so glad that you decided to join us again. I noticed that you went out in the hallway and took a couple deep breaths like your therapist and I talked about, and I'm really proud of you. We really need to reinforce those positives for them.
We sometimes use behavior management or behavior modification. We reward things we want to see and we punish. We need to be careful not to use too big a reward or a punishment. It's not like, I'm not going to love you anymore if you do that behavior, so that's your punishment or that's your negative. That would be overwhelmingly stressful, and you want to be sure that behavior management is done in a positive, loving, connected way rather than oh, you were so great, I really like you when you do that, but I really don't like you at all when you do this. That's not going to shape behavior in a positive way. Trigger is a really important concept for a lot of reasons. We sometimes think about them in terms of substance abuse, that we know a substance abuse user might have a trigger. But really it's just a reflection of our brain's capacity to learn very quickly things that are vitally important and remember them forever. It can be positive or negative. I tell in my training just about a trigger I have. If I drink a grape soda right now, just the grape taste will trigger a memory of my grandmother in Scotts Bluff. In fact, I can remember when I have that experience, I remember her house on 3rd Avenue, what the back porch looked like, what the stairs went to the basement, and right under the stairs there's a case of pop. Grape pop apparently was my flavor because that memory is tied into my brain. I think about her. I mean, I spent summers with her, so she was a very loving, good-humored, kind person that I was obviously in love with as an attachment, and she attached to me. That's a real positive trigger. But if it was a negative thing, I also spent several hours under a brass post bed in the basement when there was a tornado coming through Scotts Bluff. Well, that trauma for me, or that high stress for me, was buffered by her presence. She was there, she was, helping me process that. So that's not, I don't have a really bad trigger. But if I was there all by myself, maybe just hearing the wind or whatever could take me back to that, anxiety and anxious. So a trigger can be good or bad things.
We need to be aware of environmental triggers that may cause them to feel some anxiety. These might be smells, they might be sounds, they might be people, but we need to be aware of that and try to minimize exposure to things that make these kids feel anxious until they're ready to handle that.
It's hard not to take it personally. In the extreme, I know a story recently of a parent who was really looking at their 2-year-old like the 2-year-old was laughing at them or making fun of them. Well, a 2-year-old's not going to be making fun. That's not going to be the function of them, but that laughter was really part of dealing with stress. And when the parent could turn it around a little bit and say, they're not making fun of me, they're dealing with stress, or they're anxious, you can take it. Well, that's a pretty extreme example of taking it personally, but we all react to behavior, and sometimes we react as if they were doing it to us on purpose. And if we can step back a little bit and say, it's not me, and it's not that they want to do this, but something is making this child have this behavior, and maybe they are trying to drive me away.
With kids 6 to 18, and I think with all kids, we need to monitor our own reaction to the behaviors that they are having and the things that they may say or do that are related to the trauma. We don't want to react angrily to kids' behavior because, again, we want to increase the safety and their sense of control. We don't want to take their behavior personally. When I was in private practice before this, I used to always tell parents that they should feel good about the fact that their child is able to express themselves, sometimes in inappropriate ways, because they don't feel like the parent's going to hurt them. So we need to take what we can from that and not take it personally, that kids that are 6 or 7 that are lashing out and hitting and throwing tantrums and doing these things that sometimes seem younger than their age are really overstimulated and anxious, and they need us to jump in and help them regulate, not think that they're doing this to make me angry or they're doing this because they don't want to go to school.
None of us had the perfect relationship, perfect growing up. I mean, everybody has things in their childhood that may be better or not so good, and we just have to remember our own responses. If a child might trigger something in us where we get really mad at them, then we have to think about, well, wait a second, they're 3 years old. They're not I don't want my anger coming from somewhere else. And so we want to become aware of our own reactions and what's getting in the way.
We need to not expect kids 6 to 18 to trust us right away. Kids who have experienced a traumatic event have had some of their safety taken away. So new adults, new caregivers, even caregivers that they have already had in their life need to be aware that there's a process of building trust, and trust is built by being consistent and calm and nurturing. And this trust may come and go depending on how the kids are feeling, but recognizing that it's not just there, it's a process that has to be worked at, and letting the child know that you're willing to work in that process. And if you blow it sometimes, which I think all parents do, and you react angrily to one of these behaviors, going back and apologizing and discussing with the kid how you were feeling can be a good model for them about how you deal with feelings. And I think it's very important for people who are taking care of children who have experienced trauma to take care of themselves. I think we talk about this loosely, and caregivers nod their head and say, I do, but the things that they might be hearing from these children, especially older children, can be distressing. It can make them feel helpless, and some of their behaviors are irritating, some of their behaviors are aggressive, and that's scary. So we really need to make sure that when we're there with them, that we're fully present and that we're able to help them reduce that anxiety and feel safe. So when a caregiver is not able to do that, they're just kind of reinforcing to these kids that this is, this is how adults are in my world. So we don't want to reinforce that. We want to reinforce that, this person is safe, they're loving, I can go back to them, they're going to protect me, they're going to help me calm down when I need it, and they understand, they get kind of what's going on with me.
The key message is that you matter, that what you do makes a huge difference in influencing the development of the child's brain, influencing how they function emotionally and socially and cognitively, and that even though they may not sometimes feel like they have all of the professional labels and all of the learnings that are out there, that's in the end not as important as being present, attentive, attuned, and responsive. And in fact, the most therapeutic person I ever met was a janitor. He was incredibly compassionate, always present, always selfless in the way he interacted with children. And I can guarantee you that he had more impact on those kids than I did.
But when a kid's been damaged, the most important buffers is a consistent, unconditional, loving relationship. I mean, someone who's with them no matter what, and loving them, that's really therapeutic. Dr. Perry was pretty honest about saying, therapy, that's the therapeutic event. The psychiatrist can try to help get that into a child's life, but without that. So acting unconditionally loving, that's really important.